Okay, Dr. Xu, do you want to go ahead and get your slides uploaded? And then we can get started.
Sounds great. Hang on one second. Is it looking okay, Jennifer?
Looks perfect.
Sounds great. Ready to start.
Okay. Jennifer, you tell me, okay, when.
Go ahead. We're good.
Good afternoon. I'm Sharat Sambunwit from Infectious Diseases, and it is my honor to introduce you all to our speaker today, Dr. Katherine Xu. She's director for the Rectal STD HIV Prevention Training Center in Boston. She also served as medical director for Division of STD Prevention at the Massachusetts Department of Health. She has been our wonderful collaborator through the Rectal PTC. She also now is a professor at Boston University Medical Center. She sees adolescent clinics and also has been very instrumental in terms of guideline of treatment of Chlamydia, Gonorrhea, and general STD prevention. Her topic today is earthquakes in treatment for Chlamydia and Gonorrhea. Take away, Dr. Xu.
Thank you so much, Dr. Sambunwit, for this gracious introduction and also the invitation. And to top it all off, we've actually been spending the entire week here. And I have had the opportunity to meet so many members of the Department of Medicine. It's been an incredible ride. And of course, I felt the warmth from all the colleagues in this area, as well as the warmth from Florida, literally, because we flew in out of a 2-foot snowstorm 2 days prior to us coming here. So it's real pleasure to be here this week. We are so very lucky. Let me just get started by mentioning I have no disclosures of interest or pertinence. I'm mostly a loyal state servant for the vast majority of my time, and I do not intend to discuss any unapproved or investigative uses of commercial products or devices in my presentation. The plan for the next 45 minutes to an hour is to discuss everything and anything about chlamydia and gonorrhea. Oh my goodness, but the focus is actually going to be on rectal chlamydia and gonorrhea. And yes, this takes us back to our primary care roots. Yes, this takes us back to outpatient medicine, which is predominantly where we want the care to be, so that no patient is ever hospitalized for PID. So we will be talking about transmission, rectal, and other extragenital sites, as well as genital sites, in what was termed in many public health surveillance data sets as men who have sex with men, or male anatomy individuals who have sex with male anatomy individuals. We're also going to talk about this focus for women and how it pertains to women and why it's so important for us to understand how high rectal prevalence of chlamydia is and what role that may play in future fertility. And this has everything to do with bugs and drugs. My heart lies as a pediatric infectious disease clinician. That's what I originally trained as. We're going to talk about bugs and drugs. You know that we're half in love with the bugs that we study. So we're going to be talking about some newer transmission pathway theories. After we do that, we'll contextualize the discussion that's ongoing right now, the controversy about azithromycin versus doxycycline for chlamydia treatment. We will be reviewing the December 2020 gonorrhea guidelines, which actually then became part of the overall STI guidelines. It's just that CDC did not want to delay their release further. They wanted to get the gonorrhea guidelines out sooner. So literally 6 to 7 months before the master set of guidelines came out, they came out with the gonorrhea guideline messaging back in December of 2020. The larger context of STI concerns is, I think, front and center here down in Florida, where the population level prevalence of STIs is tremendous. And so we're going to end on some thinking about the population level concerns about bacterial load and other things. We're going to highlight some aspects of the STI treatment guidelines that should be read more closely for changes since the 2015 guidelines version by CDC. As I like to tease my residents and fellows about, I sleep with the guidelines under my pillow, hoping for osmosis, but the document is over 100 pages at this point and really stands a closer read, particularly for the subsections I'm going to highlight that have changes. And I'm going to provide some resources at the end. And hopefully, in spite of all of this, still end about 10 minutes early for some good Q&A. So, this talk, after 15, 20 years of giving talks in the STI arena, this talk is the one that has truly brought me back to my roots in STIs. I was a regular pediatric infectious disease fellow answering academic medical questions on consult services, and seldom did we ever get asked questions because it was the OBGYN service that handled GC and chlamydia and PID and inpatient consultations. Right? The last time I had thought about this arena or thought about these concepts in outpatient medicine had to do with when I was a senior resident running the ER on an overnight shift, right? So I was offered the opportunity to do a separate STD prevention fellowship. And the first thing I thought of was, well, what exactly is the prevalence of chlamydia or gonorrhea in adolescent and young adult populations? And I know this screenshot is small, so let me highlight for you the abstract that I came across in PubMed the day that I was asking this question. What is chlamydia prevalence or gonorrhea prevalence? And of 282 convenient specimens tested in an urban ER back in 2000, when the late 1990s, when this study was being done by Ned Hook's group at UAB, 282 specimens screened, 13% of them had positive findings on ligase chain reaction testing for either or both of the pathogens. And these were people who were all comers to a pediatric emergency room. They could have been coming in with a sprained ankle. They could have been coming in with a broken arm. They could have been coming in for motor vehicle trauma, but they had extra P. And on that extra P, they sent it to the lab and just did testing on every single one of them at end of shift. And this is what they found. And I thought to myself, oh my goodness, how could I have missed this tremendous area of not only a nexus of clinical medicine, high prevalence disease with implications for public health, long-term implications for future fertility. And they had me at hello. Basically, this article had me at hello. For those of you who are more graphically engaged, just think the percentage when you split it by 14, 15, 16, 17, 18, 19-year-olds, it basically runs between 10 and 20% of these specimens were positive for either GC or chlamydia. And they weren't coming in for syndromic management of pelvic inflammatory disease or a drip or some sort of discharge. This was all comers in a pediatric ER in an urban setting. So that speaks to the prevalence, and we're now swiftly going to shift gears into this controversy, which is basically that the CDC STI treatment guidelines that were released last summer highlight the fact that doxycycline is much better at microbiological eradication, absolutely superior to one dose of azithromycin for particularly rectal chlamydia. But let me bring it home as to why that's relevant for so many of our patients. Where we were in this controversy was that azithromycin versus doxycycline, there's always been this tension, but ever since we uncovered that there was a drug that could dwell in tissues and be delivered over the course of a week, which is really what that one dose of azithromycin does for you over the course of a week, it's released pharmacokinetically, it lasts in tissues for that long, versus having to take a twice daily, or if you're so lucky as to be able to locate doxycycline single daily dosing extended release materials, then yes, you could use that as well. The original studies looked at this question of the single dose versus 7 days, and in a meta-analysis, there was a shred of evidence that even at the GU site, maybe the point estimate of the efficacy of azithro is slightly less, but it was really slightly less. And everybody said, wow, I mean, go figure. Why would you choose a drug that was so slightly less efficacious, but you could deliver in one dose? It's going to beat doxycycline's efficacy just because in the real world, you're not going to eat doxycycline consistently for twice a day for a week. Compliance would always be an issue for something that's not administered as a single dose. So the question was raised about the efficacy of azithromycin through this meta-analysis, and it was put to rest by Will Geisler's study. We have to go back in history here to an NEJM study that he ran in juvenile detention facilities. In 2015, it was published in the NEJM. And here's the ultimate table of treatment failures, the efficacy of azithro versus doxycycline. Majority of the patients enrolled were women, not men, or young women, not young men. The difference in the failure rates was 3.2%. And he was, if you look at the double negative of his framing of the clinical trial results, he was not able to establish the non-inferiority of azithromycin single dose versus twice daily doxy. But most medications were effective. And although azithromycin had some treatment failures, again, the editorialist on this particular NEJM article pointed out adherence is likely to be greater than with single dose doxy. Well, fast forward to a number of years later. First of all, we now know from inquiry with our patients that sexual behaviors have broadened in spectrum, or at least the disclosures have broadened in spectrum. This is so not those Kinsey era data anymore. We're talking about oral sex behaviors, penetrative rectal intercourse, fingering, fisting, all sorts of activities going on that are disclosed by patients nowadays or cohorts in national health and behavioral surveillance data sets, which indicate that extragenital sexual interactions are occurring more and more in different populations in the United States. So this brings into play this question about extragenital sites of infection for many of the sexually transmissible organisms. Particularly, let's focus on rectal chlamydia for a moment. Turns out chlamydia is really tricky. We've never fully established the infectiousness or the reservoir for this incredibly common pathogen. The transmission has largely been attributed to asymptomatic carriers. We're down with that. The data and evidence still say many, many people carry it. Only a very few ever develop the symptoms. And moreover, sometimes it can be so silent, yet silent PID and silent infertility and chronic pelvic pain can later develop. So we do understand this to be an organism we want to screen for to prevent all of these pelvic complications in women. But many, many studies now indicate from patients who have told us that they have engaged, primarily men who have sex with men, they have never engaged in any form of sex other than oral sex. And oddly enough, they detected chlamydia at the rectum. So if you're gonna believe your patient, or as we were always taught in pediatrics, if you're always gonna believe the parent, you can't always do anything 100% of the time, but go with me for a moment here, okay? One of the theories that has to be promulgated is that when you swallow the organism can in fact passage through a GI tract, land in the rectum, and propagate there on out. Okay, it does not require, potentially it does not require direct rectal inoculation. The patient does not have to have anal intercourse and be the receptive anal intercourse recipient for this to occur. And this is a newer theory that's being promulgated basically because there are patients who absolutely swear that the only type of sex they've ever engaged in was oral sex with an infected partner, which was subsequently found, and both would verify. So this has been one interesting newer transmission pathway theory that has been raised. And so the question comes, particularly for the men who have sex with men population, shouldn't we think about the activity of azithromycin versus doxycycline? And there were a number of anecdotal studies numbering with tens of patients all the way to 230 patients, which indicated that if you looked at the positivity primarily by nucleic acid amplification testing, so PCR, right, it's not live organism, chlamydia is very difficult to culture, primarily by NAT, a number of weeks, days, weeks, months later, they had more detectable Chlamydia Trichobinis in the individuals who were treated with azithromycin versus doxycycline. But none of these were randomized, controlled, double-blind, placebo-controlled. Let me bring one more fact into play here. For women, the concern is there as well. So to summarize from this great paper by Chandra et al. In 2018, they took a look at a number of studies that related individual study and study subgroups summary estimates of rectal chlamydia positivity in women stratified by clinical subgroup and population type. So what they found, let me summarize in this bullet, attending routine clinics, all comers, women, routine clinics, not an STI clinic, not already known to be positive, 6% prevalence. 6%. That's incredible. Among those positive for vaginal chlamydia, 68%. Pretty much 2/3 of women, the point estimate from several different studies is if you already carried chlamydia from a front-end genitourinary tract infection, it turned out using reported anal intercourse as an indicator for rectal testing led to many, many missed diagnoses. That was not the indicator, whether it was because the patients had difficulty disclosing these more private sexual behaviors or potentially more stigmatizing sexual behaviors, or whether it's actually simply that sex is messy. Sex has dribble back phenomena, particularly for women. Many of us speculate that rectal co-colonization is one of the newer transmission pathways for why women are not always completely treated with a single dose of azithromycin. So what's needed? They needed to do the randomized controlled, double-blind, placebo-controlled trial, okay? And it's been done. It's now been done in two settings. More than two settings, more than two countries. The United States ran a trial sponsored by the NIH STI Clinical Trials Group. It took place both in Seattle, King County STD Clinic, and at the Fenway Community Health Center in my backyard in Boston. In those two sites, they randomized double-blind placebo-controlled for asymptomatic men who have sex with men carrying chlamydia at the rectal site and found unquestionably microbiologic cure in rectal infections across analysis groups. Now remember, everybody who was on the azithro arm had to take twice daily fake pills for about a week. So they couldn't tell which arm they were in, okay? 71 to 77% for a point estimate of microbiologic eradication on later testing. The trial was in fact stopped early due to an interim analysis. After that was published in CID earlier in 2021, later on, or just it was almost contemporaneous, a couple months later in the NEJM, Lau et al. From Australia published their similar setup trial with asymptomatic rectal chlamydia and identified a very similar point estimate of microbiological cure of single dose azithro versus twice daily doxy. What do I have to offer you in terms of microbiological estimates of efficacy in terms of eradication for women? I'm sorry, I don't yet have the data to offer from a prospective randomized controlled trial. And I think we've learned a lot from our HIV infected populations or pre-exposure prophylaxis medications do not perform the same way at all mucosal sites. So it's important to look at what little data and evidence we have at this point. There was a prospective multicenter cohort study, FemCure, in women, which indicated very similar point estimates. So let's go with this idea that single dose of azithro is not going to be beaten by doxycycline twice daily if fed to individuals for a week. Couple more thoughts, because it's very disturbing to think about having to go back to a medication that needs to be administered twice daily, or at least at a minimum once daily if you can get the extended release version, for an entire week, rather than giving them that lovely dose of azithromycin right in your adolescent center. That's what we used to do before these studies came out and the guidelines came out last year. Let me comfort you with the following facts. azithromycin performs so poorly for microbial interaction that even in the context of expected imperfect adherence in real-world use, doxycycline should be the recommended treatment for rectal CT and MSM. There are actually older studies done by people like Laura Bachman and others in the STI field, which basically demonstrated you probably don't have to be perfect with your twice daily doxycycline adherence for an entire week. You can probably get about 5 days worth of the dosing to achieve microbial eradication. Okay, I probably don't run around telling all of my patients you can basically be incompletely compliant with doxycycline, but understand that it's a little bit resilient to imperfect real-world adherence. Okay, as a clinician prescribing this is very important to be comforted by this kind of thing. One more piece. I think another worry that comes up frequently is doxycycline tends to be upsetting, certainly when taken on an empty stomach. It's got this reputation for not being so hot, for making people feel nauseous, making people feel uncomfortable. This is not a good thing when you're striving for better adherence and microbial eradication. Turns out, when they took a closer look in the NEJM study, remember everybody was on placebo for that entire week. Adverse events, including nausea, diarrhea, and vomiting, were less common in the doxycycline group than in the azithromycin group. So when it's placebo controlled and we're not being suggestive about the amount of GI distress that could or might not occur with azithro or doxy, and we're reminding our patients you should not take these medicines on an empty stomach. They actually do much better when taken with a snack, with a big glass of water, that kind of thing. People do okay with the tolerance. People do okay. Just take a look at the numbers. The data and the evidence would show us when we placebo-controlled, doxycycline actually does a little better than azithro. So let's take some concerns off the table with that. Third concern I'm going to take off the table is, oh geez, I work in a clinic. I'm so lucky. I have azithromycin to dispense, but I'm not going to have a 7-day packet of doxycycline anytime soon to give away to a patient. So how quickly after a patient is told about their diagnosis of chlamydia, do they run out and go pick up their meds? I can answer that question. I maybe cannot tell you how quickly they take the medicine after they pick it up after a pharmacy trip, but I can answer the question of whether or not directly observed therapy, which has been the gold standard for so many things in infectious diseases, right? It is so gratifying to see the patient swallow the medication and tolerate it right in front of you. You're done. One and done would have been the way to go with azithromycin dosing, right? But if you can't do that, what do the data tell us in terms of patients all across the state? In Massachusetts, we looked, and it turns out the vast majority of private providers, of course, are doing their chlamydia screening. And what they do is they find the positive and they don't drag the patient back to the office to feed them the dose of medication like we do in adolescent center. Instead, what they did was they fired off a prescription. So we called the pharmacies and we said, when did the patient pick it up? And it turned out the rate at which the patient picked it up was pretty much equivalent to the rate at which a patient who was asked to return to clinic to be fed the medication returned. Pharmacy prescriptions are frequently used. They don't go for that DOT, directly observed therapy, standard of care that we love to see in ID. And we didn't observe a significant difference in the time to treatment between directly observed therapy and pharmacy prescription pickup. So if that's comforting as well, understand that when a patient is told that they have chlamydia residing somewhere on their body, they don't usually want it there for that much longer. There are some issues with this new recommendation for doxycycline in treatment for chlamydia infection. The issue is still about chlamydia in pregnancy. First-line therapy is still single-dose azithromycin. Problem: there are now data, at least in a retrospective cohort study that Jody Dion Odom recently published in AJOG MFM, 810 pregnant women with urogenital chlamydia, it was much tougher to get rid of their urogenital chlamydia than in a non-pregnant patient population. Nearly 1 in 4 pregnancies with repeat chlamydia testing, which is recommended, it's the one population we're supposed to do test of cure in, had persistence or recurrence. Could they tell which it was? No. Were they randomized to have this data collected? No. This is still just the beginnings of observational data, but many of you on the front lines, if you've ever been involved in the care of a pregnant woman with chlamydia infection, you realize that even that single dose of azithromycin, by the time you checked up on them again, often needed to be repeated. Often their partner was not fully treated. Often we blamed reinfection. But now in the back of your head, flag the fact that it may in fact be this newer transmission pathway theory. Could rectal auto-inoculation have occurred because microbial eradication was not complete and sex is messy? So there are still a lot of unanswered questions. I know all of you in this virtual room with me today are thinking, well, why did they have to study a single dose regimen against 7 days? The competition is kind of a no-brainer. You know, you are going to have less perfect adherence with something you have to take for a week versus a single dose. Why didn't they trial, a couple doses of a higher dose of azithromycin? Why didn't they try a different strategy? Those studies are ongoing. Do not worry. But we have to wait for data. And right now, CDC had enough evidence to say, you know what, azithromycin can't be a first-line regimen anymore. That difference between about 75% microbial eradication versus over 90+% is just too great. We cannot tell patients in good faith that the better drug isn't doxycycline. It is for microbial eradication. The truth is, we still don't understand why azithromycin is failing us. We know that it dwells in tissues. So what's been taken off the table and fairly well studied is it a mechanism of action difference? Doxy versus azithro. They both target bacterial protein synthesis. Revive those thoughts in your mind from pharmacology back in medical and nursing schools. They're considered bacteriostatic. So let's create an equal playing field there. Can't be that as the reason. Antibiotic resistance for chlamydia, we'll get to that in a moment, but it is not a particularly clever pathogen in terms of its collection of resistance determinants. It has never been conclusively demonstrated in vivo that it can become resistant to a drug that it was formerly sensitive to. Chlamydia Trichobinis, not so good at that. Neisseria gonorrhea, very good. We'll talk in a moment about that. Inadequate tissue penetration of drug in the rectal environment. Great theory, right? This is definitely what I was referring to earlier when I was talking about HIV PrEP, opening up our minds to thinking about how the rectal mucosa is very different than the cervical mucosa, is very different than vaginal mucosa, is very different than other surface sites. So could this have been the reason? The Australians have already done us the favor of biopsying some individuals who volunteered their bodies for science, potentially got paid to, I'm sure, biopsied their tissue, and the azithromycin concentration was above the MIC for chlamydia for at least 14 days after a single dose of administration. So most people don't think it's actually inadequate tissue penetration of drug in the rectal environment. Could it be that all chlamydia is not created equal? Could it be that Chlamydia Trichobinis A, E, D through K, the typical urogenital strains, are not the ones that were studied in the men who have sex with men? Men who have sex with men have a higher prevalence of LGV serovars, the L1, L2 Chlamydia Trichobinis strains, and they are picked up equally as well in current generation nucleic acid amplification tests, which do not tell us the sequence or serovar type of which type of chlamydia is residing at whichever site you have swabbed and uncovered chlamydia at, whether it be the rectum, the pharynx, or the genital urinary region. Could it be that it's LGV and LGV is tougher to treat? The answer was actually found in the MSM studies. They did sequence, and LGV biovars were very uncommon in the US study. So that one, I think we can put to rest as well. So what other theories are we left with? Temporary suppression with a single dose of azithromycin. It just isn't enough for long enough. Different host microbe interactions in the rectal environment versus the genital tract. A lot of us think that's where the money is at. The rectal environment is so different than what is in the urethra, what is in the vagina, what is around the cervix. Think of all of the other microbes in the effluvium of the material in these settings, and you think about how different it is from the nasopharynx or the oropharynx, the mind starts to go crazy with these ideas that there's a lot more going on than just thinking about a single pathogen's interaction with a mucosal site, right? It's a lot more complicated. And at the end of the day, you got to go back to those bugs. Chlamydia trichobinis is an incredibly atypical organism. It requires cellular machinery to replicate and go on to develop and infect other people. And in fact, it requires a healthy host cell and a good environment that's supportive, has nutrients for the Chlamydia trichobinis to develop. And in fact, if it senses adverse conditions, it can develop aberrant reticulate bodies, exit this life cycle temporarily, yet persist. On EM microscopy, it can be seen to persist only to wait for more favorable conditions of growth, sensing that more favorable conditions, including things like increased nutrients that sometimes co-hosted microbes may be giving them. Maybe the situation is that IFN gamma is interferons are interfering with its interplay within this microbial effluvium. When it senses more favorable conditions, those aberrant RBs can go back into that life cycle and continue to live on and replicate using human host cell machinery and propagate onwards. It's just a very odd organism, and they are potentially intact and can have this sort of more quiescent phase. All right, I have made you think with a great level of detail about chlamydia and transmission pathways, men and women, sexuality, human sexualities, human sexual behaviors, how microbes interact with the human microbiome, and how we're going to treat them with the best drugs available, thinking that perhaps doxycycline is going to beat azithromycin single dose hands down at this point. That's what we have for data. So we're going to shift gears now and go into the gonorrhea treatment guidelines briefly, where the earthquake in this thing is not about transmission pathways. So let's review here. Okay, once again, we have to think about all of these newer transmission pathways, extragenital testing, screening, revealing a lot more about human sexual behaviors. And we go back to our patients and they're like, yeah, of course. And it turns out some dogma is still potentially true. Probably about 90% of urethral gonococcal carriage is actually symptomatic. If you have gonorrhea, acquire it within a day, couple days, just very short onset, you will develop a drip, and it is incredibly painful to pee out of a urethra that's infected with gonorrhea. However, what has always been known to be true is 15% of the rectal site infections are symptomatic, a much lower percentage, leading to the idea of a reservoir for potential onward transmission if that individual who's a carrier is engaged in penetrative receptive anal intercourse. And in the oropharynx, oral sex, very common behavior in many, many patient populations. Less than 10% of gonorrhea is thought to be symptomatic and gives you that glaring pharyngitis that could look for all the world like a group A strep pharyngitis at times in some unlucky individuals, or other pathogens that can give that sort of similar appearance, that exudative, painful process in the back of one's throat. Only less than 10% of gonococcal carriers in the backs of throats are actually symptomatic, leading to yet another reservoir, a very important reservoir, because it turns out the bacterial load, they've quantitated this at the rectum, is 10 times higher than the pharynx, yet the pharynx is the most common site of infection in men who have sex with men, and it is an incredibly important site for development of resistance. That gonococcus, way too clever, right? It is the organism that can trade resistance determinants with plasmid-associated resistance determinants across species. It doesn't have to have another Neisseria pathogen co-located with it in the back of somebody's pharynx. This organism knows how to have sex with other bacteria in the backs of people's throats. And what they're trading is with anaerobes, is with other gram-negatives in the backs of people's throats. And that's usually the extent of it. It's usually not a gram-positive or gram-negative transfer, a chromosomal plasmid kind of thing. But it can acquire resistance determinants like crazy. And it is on the list of CDC's most worrisome pathogens, together with C. diff, together with ESBL producers, Enterobacteriaceae. The Gonococcus is number 3 on the list. We are dreadfully afraid of an era where cephalosporin resistance will come to the shores of the United States and take us over. Why? Because the Gonococcus, every time we fired a single drug at it, it evolved and became resistant to that drug's control throughout history, first starting with the sulfa drugs, then with the penicillins, then with the quinolones, then with lots of other drugs. Not yet with the cephalosporins, but scattered case reports throughout the world still. So where did this lead CDC to go in 2015? I should have done another where we were slide. We had this idea, great, okay, it's really good at evolving resistance. Let's hit it with more than one drug at the same time. And that will produce a situation, right, where the Gonococcus has to be so creative, it has to invent 2 ways of resistance. And then maybe in a population living in a pharynx, we will be able to get away with that. That's a great idea in theory. The problem is the drug we chose, the companion drug azithromycin, has very different pharmacokinetics and was not a good second drug. And here's the other problem right now. The other problem is there's no good second drug or second class of drugs to treat the Gonococcus with. We don't have a good second drug to beat it up with. So we've got increasing concern for antimicrobial stewardship and potential impact of dual therapy on commensal organisms and concurrent pathogens. We've got PK/PD data telling us that the optimal dosing for gonorrhea treatment is a really high dose of a cephalosporin that gets distributed to several different mucosal surfaces, and to top it all off, azithromycin is only there part of the time. And what we created was a situation that was more conducive to GC azithromycin resistance, which crept up in the Gonococcal isolate surveillance project that CDC runs nationwide through a handful of sentinel surveillance sites. And what we uncovered was more GC azithromycin resistance when we struggled with this notion that we should give dual drug therapy. So CDC has now backtracked, and most nations expert now backtrack in one way. We don't use 2 drugs. That makes us all very nervous about the incoming advent of cephalosporin resistance. But the second drug we were using was becoming useless. It wasn't working anyway. Okay, so what we've done instead is our strategy now is to use a much higher dose of ceftriaxone. 500 milligrams is a single dose for persons weighing less than 150 kilos or about 300 pounds. For people weighing more than that, you should use that gram of ceftriaxone and use up those vials. Okay, and that's the take home. The second drug is added for chlamydia. Again, doxycycline times 1 week is preferred only if chlamydia infection is proven or not excluded. So the careful framing of this nuanced guidance. But let me just say that the majority of the time when you make the gonorrhea diagnosis, if the person is not symptomatic, you've simultaneously screened them with GC and chlamydia, okay? And you can tell whether or not they're chlamydia carriers too. So let us hope that new drugs for gonorrhea are coming. For the purposes of name recognition and practice solithromycin, practice zoliflodacin, gepotidacin, some of these newer topoisomerase inhibitors or cousins of the quinolones, but not exactly quinolones, like a fluoroketolide here in solithromycin's case. These are some of the drugs that we're hoping will come in the pipeline, although phase 1, phase 2 trials were showing their imperfections primarily at the site of colonization that we worry the most about. Unfortunately, many of these drugs did not succeed as well at the pharyngeal site, which makes us even more nervous. So there are other hopes, though. One wonders if there will eventually be, as there is in Europe, a molecular diagnostic that can tell us whether the patient in front of us with gonorrhea at that moment in time is a carrier of a quinolone resistant strain or a quinolone susceptible strain. A lot of gonorrhea strains are still susceptible to current quinolones. If only we knew who carried them and could use a single dose of an oral medication. How lovely would that be? Yes. The development of these commercially available assays has already started to happen in Europe, and it's a matter of time before they come to the United States. And this idea that molecular diagnostics can tell us in real time and help us guide resistance-guided treatment of gonorrhea rather than waiting for a culture of the pus or the drip to come to light, grow on a plate, be tested, or have serial dilutions run on it, which takes days. Days when the patient is symptomatic, days when the patient, you're just waiting for that additional drug. Very concerning. And maybe molecular diagnostics will come in and save us sometime soon, next few years. If we think about the patients in front of us, and we only think about the patient in front of us without having a discussion about their treatment of their partners, the odds are not low that that patient will return to us with a reinfection, right? So many states in the nation, Florida included, have legalized and then regulated what's called expedited partner therapy. So not only can you treat the patient in front of you, but you can get the patient in front of you to take medications home for their partner. Or better yet, at a DOH site near you, ask that partner or that patient to stop in at a partnering pharmacy and grab the meds and have them distributed directly from patient to partner. You're going to say, well, what meds should I use and who's a candidate? Evaluate all sex partners. Empirically treat all sex partners. There's been a broadening in recommendation and a concept that, you know, the concept is generally that better is not the enemy of best. If the partners are the cases are in an abusive relationship and the partner just will not come in for care, whatever is happening, maybe is it better to try to get the meds at least to treat the partner into the partner's hands, even if they won't come in for care and other STI HIV testing, which would be so important for population level health, particularly in populations that co-carry multiple STIs, such as MSM. That was the big concern. Studies were never specifically run in that population with co-infection rates, but better is not the enemy of best. And certainly, if a patient reports that their partners are unlikely to come in for care, many of us use expedited partner therapy for this purpose. What are you going to use? I know many a patient in my own personal panel who would have loved to deliver that shot of ceftriaxone into the partner's musculature of the partner who gave them the gonorrhea. But that is not currently one of the acceptable regimens. We do go with oral cefixime, and the one notable change and the earthquake in gonorrhea expedited partner therapy is we don't use 400 milligrams, we use 800 milligrams. There is a shred of evidence that this is tolerable. Again, probably better not on an empty stomach, and shifting to 800 milligrams PO times 1 of oral cefixime is probably the way to go for gonorrhea. For chlamydia, oh, geez, what are you going to do with the partners? Are you going to give them doxycycline for a week and know that a lot of the times it doesn't even get to the partner? Or are you going to take the hit and use azithromycin? Many of us are thinking about parsing out who is the least likely candidate to have rectal chlamydia infection, and that would be the male anatomy patient partner of the female anatomy patient that you are treating in front of you. You want to expedite that male anatomy patient's treatment for chlamydia as a partner that you're not going to get a chance to examine or test for other STIs. That's probably the one category of individuals where azithromycin can still be used, because male anatomy patients are unlikely to have co-carriage at the rectal site. Perhaps sex is not that messy. So in the last few minutes that I'm going to deliver this didactic section of the presentation, let's talk about the larger context. We've drilled down on gonorrhea and chlamydia to a great extent here, but the larger context is the one that we all lived in before a pandemic took over our world. We are now back to 80s levels of STIs, and one wonders during the pandemic how much screening has been missed. Screening could not possibly have been the priority during the pandemic. So let me give you the evidence for that. These are data that Florida State has reported to CDC for many years. In fact, 3 decades are summarized here. And I think it's fair to display syphilis and gonorrhea because they've been relatively intact and impervious to the winds of how the cases are defined. We've been tracking the diseases forever. And NAT diagnostics, nucleic acid amplification testing, and diagnosis did not impact gonorrhea the way it did and frame shifted and how we found how common chlamydia was in terms of carriage. So it's not really fair to display chlamydia on this graphic because NATs took hold in the 1990s. Yeah, it's been that long. So it's not totally great to do that. So I've only displayed syphilis and gonorrhea. They are our canonical bacterial STIs that we've been monitoring for a long time. And what am I trying to show you? I'm trying to show you this U-shaped curve that basically tells you that we have gone back to the 80s in not a good way. I love going back to the 80s. Like, let me tell you, DJ Jazzy Jeff and the Fresh Prince of Bel-Air and them jamming and doing scratching and records and dancing and all that good stuff. I grew up in the 80s. Does it show? But the going back to the 80s for 80s levels of STIs is probably not a good way to go. So some of you are going to look at this graphic and say, is Florida unusual or is Florida like the rest of the nation? Florida's like the rest of the nation still. In this respect, I think it's fair to say many jurisdictions saw a downturn in the 90s and 2000s. Other people are going to look at this graphic and say, wow, what were we doing right in the late 90s? We were doing something that was not a good idea and is not something that public health will go back to. The decreases in syphilis and probably gonorrhea cases were due to both behavior change under the penalty that you might acquire an STI that could kill you. HIV was not controllable necessarily. Antiretrovirals and CART and HART were twinkles in people's eyes. What was really happening was that co-infection in the syphilis and HIV co-infected population was trimming the population prevalence of syphilis, in addition to this HIV syphilis connection to HIV gonorrhea connection. So deaths were occurring in the HIV syphilis co-infected individuals. This is not a good strategy for public health, right? So we can't go back to that strategy. And everyone wonders what's going to happen once the pandemic or becomes endemic, I suppose, and we have less and less coronavirus to worry about. What are the numbers and data going to show us? Already preliminary 2020 numbers show that incredible dip when the trend was not present at all. And I think we are all smart enough as clinicians to realize human behavior doesn't change that much during a pandemic. It can, but not forever. So this leads to the CDC's latest fear-mongering graphics about the state of STDs in the United States in 2019, 1.8 million cases of chlamydia, 6,000 plus cases of 600,000 plus cases of gonorrhea, 129,000 cases of syphilis, and oh my gosh, a resurgence of congenital syphilis that most people who worked back in the 80s can't even believe. And STDs increased for the 6th year, reaching an all-time record high. And every single infection that's reportable and nationally notifiable that's an STD, when compared to cases reported in 2015, has gone up. I think there are those of you in this virtual room with me that may remember that chlamydia, in fact, was the most commonly reported notifiable disease before coronavirus. These national numbers don't tell the full story, though. While the problem of STIs is enormous and growing at any state or county level or within clinics, what epidemiologists and clinicians who see the individuals named, the disease intervention specialists that we work with in public health, they see that patients return repeatedly infected with STIs. So I think this leads us to understand that disproportionate impacts are seen on certain individuals and populations. A lot of this can be reinfection. Remember, CDC doesn't get them deduplicated by individual name. They don't get named individuals. But at city, state, county level, local action, we can see this. And well-applied clinical interventions such as STI screening and effective STI rapid treatment and management of partners as well can still improve the state of STIs even before we get vaccine to save us all, okay? Which, as you all know, is not an easy save. As quickly as biological systems progress, they can regress. And I think COVID has certainly blown our minds as to frequency of screening. This concept that we were just screening annually for chlamydia and gonorrhea, start to pitch that out the door. And think about quarterly for your high-risk individuals. Certainly it's recommended for MSM on PrEP or any individual on PrEP to have quarterly monitoring. Should it go to every 2 months? Some people are starting to question that in modeling studies. So I think the direction to think about, antecedent to vaccines coming in for chlamydia, for gonorrhea, for other infections that are sexually transmissible, rescreening for STIs in those previously infected reaches those at highest STI HIV risk. The individual that just had an STI basically just called them out for, please call me back for a test of reinfection in a few months. The other thing that I think we weren't doing during the pandemic that I hinted at earlier is that we have evidence that although gonorrhea has come back in 2021 to match above 2019 numbers, skip pattern for 2020 and COVID's impacts, okay, what we have uncovered is chlamydia has not. And chlamydia is predominantly asymptomatic, as we discussed earlier during today's grand rounds. So recalling people for routine screening will be incredibly important. We don't want to miss this for future sexual and reproductive health, particularly in women. Of course, the other thing that we can do when we identify red flag STIs, for example, in men who have sex with men, diagnosis, rectal chlamydia or gonorrhea, red flag, they just reported out, they essentially told you that they are likely engaged in penetrative anal intercourse, which is a setup for HIV acquisition. You can see the adjusted hazard ratios if you had 2 or more episodes of rectal chlamydia or gonorrhea, the more common pathogens. Let's hope you started with those. We could cure those. And a goodly proportion of these individuals never became HIV infected. You're not absolutely doomed. Don't misread the data, but even better, these are data from 2010. This was Kyle Bernstein's San Francisco City Clinic material. There are lots of other data sets that indicate this. There are Florida data sets that say if you had syphilis or rectal chlamydia or gonorrhea, your time event horizon to HIV acquisition is that much shorter. But we now have HIV PrEP. We now have HIV PrEP and biomedical HIV interventions that did not exist at the time that Kyle and his team did this study. The last message I'll leave with you is that with this increased incredible incidence and prevalence of notifiable STIs, we are going to have to focus our bandwidth as clinicians on managing more and more complicated disease. At the state level in Massachusetts, we are seeing breakthrough cases of neonatal conjunctivitis due to gonorrhea and chlamydia because the base case rate in pregnant women has gone up. Despite good screening efforts, acquisition or reacquisition of disease can happen, and prophylaxis is not 100%. So if 3 out of every 100 cases do not respond to that ribbon of erythromycin that's routinely applied to in-hospital births, cohorts of infants, if there is some failure rate, you increase the base case rate, of course, you're going to see more breakthrough infections. The same goes for odder presentations of typical things. So in the bottom left, there's this gorgeous graphic from a chancre that Nicholas Fiumar, our former dermatovenereologist that practiced in the state of Massachusetts and then later became our state epi and donated his entire 35mm slide collection for teaching purposes to the State Department of Public Health. He has this amazing slide of a chancre that he dark fielded and found Treponema patalinum tumbling around on the dark field microscopy specimen. And it was between the great toe and the second toe of a commercial sex worker back in the 80s. That's how he made that diagnosis. And I will just let your mind go free as to where those toes were, that was the portal of entry for syphilitic organisms. The other case that came to light recently was an incredible disseminated gonococcal infection case that was basically a calf abscess. It took over a month to make this diagnosis because the initial imaging thought that this was just a hematoma. It was interpreted as a hematoma. And when it didn't go away and the patient gradually had an increase in low-grade fevers, eventually they took material from it. Lo and behold, it was purulent, stained it, and there the gram-negative intracellular diplococci were. Wouldn't you go figure? And it was over a month to make that diagnosis. Strange presentations of rarer forms of gonococcal infection, disseminated gonococcal infection. We are also seeing more and more breakthrough cases from what essentially gives us evidence for the fact that screening was imperfect 10, 20 years ago, and somebody has progressed along the syphilis stages to the point where they can actually have a syphilitic aortitis, arrives in the OR, has the pathology demonstrating the thoracic aorta has treponemes in the thoracic aortic wall. That was how that diagnosis was made. And with the thought that secondary syphilis is becoming more and more common, secondary syphilis being nothing more than a progression from beyond the chancre stage to treponemes and spirochetemia of those spirochetes. During that phase, dissemination can occur to central nervous system, can occur to cranial nerves. And I think many of you have now gotten more familiar with neuroocular and otic manifestations of syphilis. Incredible presentations, because it turns out neuroocular otic syphilis occur in about 2 to 5% of all secondary syphilis cases. So you go from 100 to 1,000 cases of syphilis. Of course, you're going to go from 3 to about 30 cases of this. And you're going to start to see this in training. You're going to start to get more familiar with it. And you're going to start to realize, oh my goodness, I need to screen my patients systematically for recent changes in hearing, vision, and cranial nerve symptoms. These are well worth your time to use a simple tool such as this one that was developed by Seattle King County STD Clinic for anyone to use. Our field epidemiologists, our DIS are using this on patients that we interview for secondary syphilis. And it has been incredibly powerful to be more systematic at picking up individuals who need that higher level dosing of IV penicillin administered to get rid of the treponemes and finally cure that syphilis. The shot of IM penicillin, benzathine penicillin at the 2.4 million units level is not going to do it for patients who need penetrance into CNS, otic, and ocular environments. So in summary, let me leave you with the following take-home messages. Rectal chlamydia infection is common in MSM in women. Doxycycline times 1 week is now recommended over azithromycin times 1 dose for chlamydia, except in pregnant women, particularly for rectal chlamydia or suspicion of rectal infection. And I just got done telling you, you should be suspecting it in 2/3 of the women that you treat for genital urinary chlamydia infection. That Dombrowski paper, I do favor it because it's done in the US environment, is worth reading for some of the concepts about letting go, about adherence concerns and ramping up on counseling to increase adherence, cell phone reminders, mid-treatment check-ins with your team. Azithromycin times 1 dose is probably still fine for purely urogenital chlamydia infection, but this is a very limited subset of patients. Use those gonorrhea guidelines, but don't get too loyal to them. Expect so much change in the coming years with gonorrhea guidance over time as we become reactive to what molecular diagnostics tell us about how we can repurpose drugs and potentially reuse other drugs to treat gonorrhea or newly invented drugs that are newly licensed. Time to ramp up back on routine screening. Okay, Omicron really needs to let its teeth let go of us to decrease complications and symptomatic disease. And let's go for the green here. Catch up of routine healthcare, screening, vaccinations, not limited to sexual health. needs to be done post the pandemic, which involves recalling patients and having systems really do a better job of routine healthcare maintenance. And recalling patients for that devilish test of reinfection a few months after the original test is incredibly important to stop circulating bacterial load within communities. For those with prior STI, they do deserve that callback. Some resources for you. Oh, those STI treatment guidelines that I sleep with under my pillow, expanded extragenital screening recommendations in adolescents and young adult women, a new section in Mycoplasma and genitalium. If you're not worried about it yet, I don't want to get you too worried. The diagnostics are not always present everywhere, but it's worth skimming to understand that there's a new kid on the block that really has been known since the 1980s and may potentially be correlated certainly with male urethritis that's persistent and yet is not due to the Gonococcal or to Chlamydia Trichobinis. But whether or not it's quite as tightly associated with PID and upper genital tract outcomes in women is still in doubt. So I don't want people to fret too much, just enough. Removal of the LP recommendation. Yes, we can actually back down on recommendations. It was realized in the most recent studies that for purely ocular and otic symptoms, really, you don't need to LP these individuals. The LP doesn't change the management ultimately in the latest studies. So maybe purely ocular and otic symptoms, don't do the LP or arrange for the LP. Instead, just get them on the IV penicillin quickly if they are not allergic. Changes in recommended treatment for chlamydia and gonorrhea is what we spend the bulk of the time on, have dominoed into changes though for all the forms of syndromic treatment that we would do for sites of the body that have itises associated with chlamydia and gonorrhea. So take a closer look at how we approach cervicitis, urethritis, and PID as well. Secnidazole for BV is a new drug on the block for bacterial vaginosis. And metronidazole, I have a couple new messages for you. There is a preference for the 7-day over a single dose regimen. I think you're hearing the pattern here. Unfortunately, trichomoniasis, that 2-gram stat dose, really has not been shown to have microbial eradication to as great a degree as the 7-day regimen. And this can present tolerability concerns, definitely in patients who have both metronidazole and doxycycline needed as preferred pre-ID treatment regimens have also incorporated metronidazole now. One good news piece in terms of backing down on things that we warn patients about, alcohol abstention is no longer recommended by CDC. Ethanol alone may explain many of the previous reports that reported a disulfiram-like reaction, because it turns out metronidazole doesn't inhibit acetaldehyde dehydrogenase as occurs with disulfiram. And let me tell you, the problem will be that, of course, the pharmacist dispensing the med, the FDA approved language still includes some language, I believe, about needing to alcohol abstain. But CDC says maybe you can let go of that counseling. Those STI treatment guidelines, the biggest argument at the treatment guidelines meeting was really how to name them. And we moved, the big move was from STD, all about disease, to silently carried infections, STI treatment guidelines. But that's still a misnomer. They are prevention, screening, counseling, management, and treatment guidelines. There's a whole table of contents on the web. And we hope that there will be an app available soon that links you to those of us in what's called the STD Prevention Training Center network, of which I'm but one of many people who love to talk your ear off about STDs when you're managing a vexing conundrum or a case on the front lines. Write us an email, de-identify the patient, ask us a question. We'll be there to help you within 1 to 5 days or even less, and you get to request how you get the call back. Email, phone, within an hour, do your darndest. And soon the STI Treatment Guidelines app should link to that STD Clinical Consultation Network, where faculty, I replaced the stock photos with pictures of all of us on the front lines of call. I probably should let you know that Dr. Leandro Mena, who has now taken over as the CDC Division of STD Prevention Director, should not be on call on the front lines for these questions anymore. And I need to replace his picture. He was doing the honors for one of the PTCs down south before. I am in charge of a fleet of faculty in New England. Christine Johnson is up at UW. So wherever you go in the nation, your question will be triaged to the appropriate PTC with very friendly people that do love to talk your ear off about STD management. We do love it. All right. I will stop there, stop sharing. Charlotte. Oh man, I ran right to 1 o'clock.
Yeah, thank you so much for the wonderful presentation that remind us how much we miss in-person meeting. I can see that all the energy. I was really literally sit behind in the back of the room, and I almost see that you're almost about to stand up several times. So I just want to start with the first question, and I'm asking a question from the floor as well. For this new guideline and the stewardship of treatment for gonorrhea and chlamydia, it seems that it is more difficult to treat now.
Mhm.
How do you make the catchment into primary care and also post-exposure prophylaxis?
Yeah, I don't think we can, like, one strategy might be to wait for better data and potentially more evidence on azithromycin and its utility in a shorter dosing regimen, right? But I don't think those data are ready for prime time anytime soon. So I'm anxious about that. And I think the move does have to be made to just shift gears and go to either once a day or twice a day doxycycline, because otherwise we're doing our patients a disservice in this interim time period where we don't have better treatment regimens. So the question is not, is the drug better at doing its job? It's a question of adherence, which is going to need more support. And I know that's really difficult, right? Especially for adolescent and young adult patients, it's all about adherence. So yes, calling them to see if they picked up the medication and if they're actually taking it and how they're tolerating it does make a big difference ultimately in whether or not they actually get that infection eradicated. I think we're just going to have to bite the bullet and switch temporarily until we get better drug regimens that are shorter.
Thank you so much. I want to see if there are any questions from the group. Okay, Kami, please go ahead.
Yeah.
So I have a question, because a lot of times there's the whole, someone comes in and then there's the lag to what to do and stuff like that. What do you think is going to happen with point of care testing? Because, you know, a lot of family practice settings, and I mean, obviously STI clinics usually have the array, but even they don't have everything. But, you know, really, it would be good to have it really out in the community. So what do you think is going to happen with point of care or other things that make it easier for people to get diagnosed?
Yeah, I think, you know, your guess is probably better than mine, Kami. But the writing's on the wall. COVID has sped all of us up, right? And the expectation nowadays for how quick a diagnosis can be made, should be made, has really changed, I would argue. There already was, oh my gosh, one of the platforms already was able to make a half-an-hour PCR diagnosis that was essentially just as sensitive and specific as the ones that take about a day to turn around. I know you guys are currently using the Aptima GenProbe Hologic Panther platform. You usually get a result within a day or two, right? Depending on how quickly your specimen is uploaded in the hospital lab. But there was already a version, it wasn't by that company, but there was one that could give you a half-an-hour diagnosis that was equally sensitive and specific through NATS. And it's just going to get better and better and better. It's not going to be through antigen. It's not like COVID antigen testing. And nor do we want it necessarily to be that way. It will actually just be that the NATs themselves get more technologically feasible to be run as rapid PCRs, I think. That's my best guess. What do you think?
No idea, but just was curious because I think that would, you know, you want to get the tests more accessible to real people, particularly for, you know, these high risk colonization things that you want to take care of. You know,
that platform that I'm referring to, that name is escaping me right now, but it was used in several of the international studies because they like to collaborate with some of the international sites as well. So I think accessibility may be one issue, but certainly transport and feasibility of self-collected specimens mailed in and how shelf stable that specimen sample is to a site that can then turn around the result very quickly, that technologically is already feasible.
Great. Thank you so much. I know there's a lot of questions still. Here I see another hand. Dr. Tony, please go ahead.
I'm just wondering if you had any additional information from Charlotte Gatos at Hopkins, since she spends a lot of time looking at these I know they were looking at trying to come out with an adapter for iPhones, trying to make rapid diagnosis of at least gonorrhea, but that's going to be fraught with a lot of different things. Anything new on that
Yep.
front?
Oh, I did not plant you in the audience to ask me this question, John, but I will mention that there is an upcoming CDC sponsored, whether you think ill or positively of public health. They are more agnostic than a purely industry sponsored meeting. And they are having their annual, right, it's the HIV and Hep C diagnostics meeting. And for the first time, STIs were invited to party with them. So STI diagnostics are going to be front and center, and a lot of industry individuals and researchers will be present at this meeting in March that's being held virtually. So I'm really looking forward to it. It was the one meeting that I put a pin into my calendar and really heavily blocked because it's the first time STI diagnostics are actually going to be part of this meeting platform. Okay, so I think that's going to be really high yield for learning a lot more about what the field is interested in developing or what is already being developed behind the scenes by lots of different individuals, including public health, which is not always the fastest. That one's up in March. Just Google CDC Hep C HIV STI diagnostics meeting.
Thank you. Thank you, John, for the question. Any other question from the audience?
We have a question from chat from Dr. Guerra. So as part of a routine Pap smear, should we be doing a rectal swab?
Do you mean for the purpose of HPV screening? Okay, so I'm sorry, I don't know Dr. Guerra's background, and I'm wondering if this is about an HIV
This is
positive population?
The same Lucy we had.
Oh, yes. Okay. So I'm sort of thinking about how to divide, like, who needs anal paps? Or was your question more about GC and chlamydia routine screening at the anal site?
Well, I was sorry, I couldn't unmute myself. No, I was just wondering, like, should we be doing a PAP for GC chlamydia of the rectal area? I mean, not a PAP, a rectal swab. Just anybody that comes in.
Yeah, sure. Well, certainly the question has come up numerous times, whether in young adult and adolescent population, should you just go ahead and do 3-site screening in everyone, let alone male anatomy patients who have sex with male anatomy patients? Because the prevalence has gone up and the transmission, therefore, if there's enough in the reservoir, transmission can happen. So if you want to stop circulating bug in a population, you're going to have to seek it and find it. I think the truth is, if many of you either don't have rapid access to a rectal diagnostic, you should just go with the information that I was able to pull up, which is that 2/3 of women are co-colonized, period, end of story. Do you necessarily need to sieve out the ones that are precisely co-colonized before you bite the bullet and do doxycycline twice a day or once a day for a week? That can be personal clinical choice, I think, still. You could, that's right, you could do 3-site testing and eliminate the rectum as a question on your mind, since all of these assays are now approved. Now, what you're terming a Pap smear, yes, Pap smear materials can be used for GC and chlamydia screening, but that's not typically the way I do it. I simply do it using a platform and a swab that's okay to be used at an extragenital test. That's how I usually functionally do it. I don't do it on the same swab that necessarily I do the anal Pap on.
Okay, thank you.
Thank you so much for the questions. Any other questions from the audience? This is really great. I see Yuli, Dr. Shou is having a question.
Hey, Kathy, great presentation. The limited EPT performed in Florida has been centered around chlamydia. That's pretty straightforward. Just your thoughts on Cefixime and the gonorrhea piece. I thought some of the limitations in the past was the recommendation of test to cure, which obviously isn't practical in an EPT setting. So what are your thoughts there? And has Boston implemented that piece of it?
Yeah, I'm still getting off easy because the legislature did not, in their infinite wisdom, see fit to legalize EPT both for chlamydia and gonorrhea. And it's been really hard once it's law and it's only explicitly regulated for chlamydia, it's actually been hard to go back and reconvince the legislature to take it up again and broaden it for diseases of public health significance. It doesn't even have to be limited to sexual transmission, right? I mean, so many of us treat scabies patients with sight unseen, not necessarily examining them. And it would be nice to have the legal protections in place that allow physicians and nurse practitioners and nurse clinicians can examine patients, not to necessarily have to examine patients for diseases of public health significance. So I have not yet had to regulate or do the terminology around Cefixime, but I know that pretty much California and multiple other states have switched gears and long since gone up. I shouldn't say long since, for about oh my goodness, it's almost been a year since those new gonorrhea guidelines came out, Uli, in December of 2020, a little bit earlier than the rest of the guidelines. So it's been about a year that most people have shifted gears to 800 of Cefixime. We also, in practice, have a lot more anecdotal evidence that it is tolerated, because remember, it was one of the drug treatment regimens that we used for syndromic treatment when a patient just wasn't able to come in during the pandemic. So I think there is better evidence of its safety and tolerability, and I'll leave it at that. We do think that Cefixime's levels in the oropharynx are never quite as good as ceftriaxone's, which of course makes everyone very nervous about the inception and the development of gonococcal resistance. But if that partner doesn't come in and you have a patient repeatedly getting infected, your options aren't great. Great question. Thanks, Uli.
Excellent. Any further questions from the audience? We really appreciate you spending lunchtime with us. We do miss the in-person meeting, and we hope that Dr. Shu will come back when we can do it in person. And thank you so much for being here with us.
Yep, I'll stay on for anybody who wants to say hello or come on camera for a few more minutes. Oh, Karina,